It's time we start. Good afternoon, everybody. Thank you for joining the webinar today. We are glad in this presentation of today, we are going to have Dr. Nasir. She's the one who's going to start with us, and we'll also have Imelda, who will follow after Dr. Nasir, but we're going to start with Dr. Nasir as of now. And Dr. Nasir works in the Ministry of Health, and she is also the local person of mental health and legislation and system threatening. She has a Bachelor of Pharmacy degree and a Master's of Science in Global Mental Health from London School of Hygiene and Tropical Medicine and King's of College of London. She has actively been involved in policy and strategic formulation at the national level. Nasir has also coordinated a number of national mental health projects, including the mental health response during the COVID-19 pandemic in Kenya, Kenya Mental Health Investment Case, Workplace Mental Wellness Program, and the World Health Organization Quality Right Initiative. Dr. Nasir is also coordinating the National Suicide Prevention Program. Her strength lies with policy making, stakeholders engagement, and resource mobilization. She's going to take us through a structural analysis, supportive policy, legal and financial environment. Having said that, I wish to welcome Dr. Nasir to take us through her presentation. Welcome, Dr. Nasir.
Thank you. Thank you, Matilda. Let me try and share my screen. So good afternoon. So I will start with, I'll give a brief of the situational analysis, and then I'll move now to the supportive policy, legal and financial environment. I hope my slides are clear. If not, please put it in the chat. So I'll start with global statistics. Globally, over 700,000 people die by suicide every year. This is according to the WHO in 2019. And every 40 seconds, we lose one person by suicide. And for every suicide, 20 people attempt suicide, and many others have thoughts of suicide. Suicide is also the fourth leading cause of death, especially among young people, among 15 to 29-year-olds. This is also not just globally, but across the different regions, especially in the low and middle income countries. Highest burden is observed within the low and middle income countries, like our own in Kenya. And this is mainly due to the huge gaps in our health systems, our gaps in resources, and also there's a limitation or gaps in early identification, treatment, and support. Research or evidence is also showing that men have higher rates of suicide than women, although women have more suicidal attempts, and women have higher rates of depression. Globally, the most common means of suicide is ingestion of pesticides, hanging, and firearms. In Kenya, WHO estimates that our suicide rate is at 6.1 per 100,000, which roughly translates to about 4 suicides a day. We know that this is underrepresentation or underreporting because of weaknesses in the accuracy and quality of the data that we have in the country on suicide. So this is mainly contributed to the nature of reporting systems for suicide are fragmented. It's being done by different organizations and different agencies. We have the Civil Registration Service. We have the police also collecting data. We have mortuaries and morgues. And we also have data being collected at facility level, which there is no central reporting system for suicide. So that greatly is a hindrance for us in terms of what our numbers are. We are not sure what the numbers are. We are currently relying on estimates for these suicide rates or suicide deaths in the country. Also, data for self-harm or intentional self-harm. It's very difficult to distinguish from the cases that we already have of accidents or homicide. And most of the time, they don't end up within health. They end up within other agencies. In this case, they'll end up within the police for investigation. Also, we have partial data. Data is not being collected on method of suicide. I think also this can be attributed to a lot of factors in the country. One is also culture. And also there's a lot of stigma around suicide. So people would lie even about suicide. Families would not be willing to say that this person died by suicide because they don't want to be branded as the family where people die by suicide. And I think you can note that I'm not saying committed suicide, because committed suicide, we are moving away from saying that. We're saying died by suicide, because committed suicide means that they committed a crime. It's a crime, and that's not what we want. That's also propagating more of the stigma that is already associated with suicide. The other issue that we have about partial data on means of suicide is a lot of suicide. We are seeing a lot of suicidal attempts and suicide cases which are happening in the country. They are being reported as poisoning. So you don't know if it's self-inflicted poisoning. You don't know if it's poisoning by someone else, which would be a homicide. So there's data on poisoning we have in the country, but we can't really tell if this is self-poisoning or poisoning by another party or accidental poisoning. So it brings a very big challenge for us in terms of segregating the data that is there on suicide. For us right now, we are seeing that there's urgent need to strengthen the surveillance system for suicide, because without data, we are not able to make informed decisions. And without up-to-date, because we are using our estimates that we have. We're not able also to gear funding to that area because we don't know what is the gravity of the situation. We see a lot of suicide deaths even on the news, but we are not able nationally to say today this number of people died by suicide. So I will give a glimpse of what is contained in our National Suicide Prevention Strategy. We launched this strategy in the year 2021. It's a 5-year strategy. I will go through the 5 strategic objectives just to give a glimpse that suicide prevention is multidisciplinary, multi-sectoral. We can't do it just as health. We can't do it only within the health sector. It requires other agencies on board on this. So the first one is on leadership and coordination. Here we are asking for establishment and operationalization of national and county suicide prevention programs. This is to provide leadership and multi-sectoral coordination. I think as you have seen about suicide is that there are a number of agencies involved in suicide. I'll cover that in my other slides. Also, we need to strengthen what we're discussing today really is to strengthen the supportive policy, legal, and financial environment, because without this, it's very difficult to implement strategies for suicide prevention. And also access to comprehensive services, including risk reduction, screening services for mental health, early interventions, even in schools, at workplaces, support linkage for people who require, or people who have attempted suicide, or people who are having mental health challenges, or people who even are having suicidal thoughts. And we are scared, I think, as a community or as a lot of times, is that we don't want to ask about suicide because we are worried if we ask, the person might attempt or complete their suicide. But studies are showing that that's not the case. It's important to ask and talk about suicide. There's no evidence that shows that it actually increases the rates of suicide in that population. Then there's public awareness and stigma reduction. There's a lot of misinformation about suicide. There's a lot of myths about suicide. There's a lot of beliefs around suicide. And we need to do a lot of targeted interventions, especially targeting, they are called gatekeepers. Gatekeepers are people or individuals who are able to prevent suicide. And they usually they are like fast responders. We have fast responders in emergencies. So here the gatekeepers we have is, some of them are media personnel, because media is a gatekeeper. Media is the one who will also show on the news that someone died by suicide. And we're also working right now with a media fraternity to come up with a mental health curriculum, because sometimes they even give the suicide note, the means of suicide, the drugs which are used for suicide, and that is against the guidelines which have been set on reporting on suicide. Also, we have schools, teachers. Teachers are gatekeepers. You know this child, you can see this child, something is going on with this child. And if you're able to screen this child, do early interventions, you can alleviate a lot of suicides, especially among young people. The other gatekeepers we have is community leaders, provincial administrators, the chiefs. They know what's going on in the community. The Nyumba Kumi initiative that we have in Kenya, these are people we need to train on how to look out for people who might be at risk of suicide and give them the necessary support. Healthcare workers as well. Studies are also showing that before someone attempted suicide, if I'm not wrong, I think is it a month before they died by suicide, they had contact with a health facility or a health provider. So a very good gatekeeper who we need to train on suicide prevention are healthcare workers. Because a lot of the times when you come there, you can come there even a suicidal attempt. And we see this a lot in our public health institutions. We see organophosphate poisoning, but we don't query, we don't go further to find out this person clearly needs mental health support. Do we link them with mental health support? Do we try give some form of brief intervention? Or do we just, we manage the physical? If they have a cut, we manage the physical symptoms and we send them back home. And then after a few days or a few months, you hear that the person died by suicide, or you hear that the person died. Because most of the times we don't also report on suicide because of the associated stigma. Then strengthening systems for surveillance and research. I've briefly mentioned this. As a country, we're working on probably having some form of a national suicide registry because the data is in different organizations. It's kept in different agencies. I highlighted some of the data is within the Civil Registration Service, who collects all the deaths information in the country and births. Some of it is within the police. Some of the data is in the mortuaries and in the morgues. Other data is in health facility level, which we are collecting through our health information system, but they are not speaking to each other and they are not linked. So we have different data, and we also don't have a standardized reporting tool for suicide, which we are working on right now to develop that. So I will start with supportive policy and legal environment. What does this entail? So this one is countries need to develop national suicide prevention policies and strategies, and evidence is clear about the impact of this, because as I don't know if you're aware, but suicide is part of one of the targets that we need to meet, reduction in suicide rate by all countries as part of our SDGs. So most countries who have been able to develop national suicide prevention policies or strategies, including Japan, was able to clearly show that implementation of this policy, the suicide prevention policy, it reduced the suicide deaths in that country. So we've done that as Kenya. We have, if you look on my right, we have the suicide prevention strategy 2021-2026, which we are currently implementing. Number 2 is decriminalization of suicide. This will be covered by my colleague Imelda, but just to mention briefly is that the Penal Code in Kenya, section 226, criminalizes suicidal attempt. And if you have a suicidal attempt, you're guilty of a misdemeanor. So this is preventing people from coming out and saying this was a suicidal attempt because it's against the law. So I think that is why Imelda will speak more on this, because she's on the parliamentary side, on the legislative side, and be able to explain what this means and how can this be addressed in the country. Number 3 is on enforcement of regulation laws to restrict means of suicide. In Kenya, we have good policies, we have good laws, we have good regulations which are already set, but the enforcement is where we need to emphasize and probably put our investment in, especially on those which restrict the means of suicide. So the means of suicide are many, but here I'll just mention 3, which we are working on currently, is the control and use of illicit narcotics. There's already regulations for this with the Pharmacy and Poisons Board. So we're working on doing capacity building and enforcement of this by the regulators. So this is very important to us because of access to the narcotics, the illicit narcotics, and a lot of the opioids. Number 2 is control and use of pesticides. I think we haven't done research on this, but what small pockets of studies which have been done in the country is showing the most common means of suicide in Kenya is organophosphate poisoning or pesticide poisoning. So we're working with the Ministry of Agriculture at the moment to come up with some form of enforcement or come up with guidelines on the control and use of pesticides. 3rd is also access to firearms. This one we're working with the Ministry of Interior and the Firearm Licensing Board to also come out and do enforcement. And I think this has already been taking place, whereby if you want to possess a firearm, you need to have a mental health, the mental status exam done for you, and you have a clean bill of health mentally, then that is when you can get license for firearms. So 4 is also development of new guidelines. We might need to develop new guidelines, new policies, which may not be there, or implementation of existing ones. So in management of pesticides, this is an area where we felt after discussion with Ministry of Agriculture, we might need to come up with guidelines on this, multi-agency guidelines whereby we'll have many stakeholders on the table to be able to come up with proper guidelines on this area. Then training of gatekeepers. I talked about the gatekeepers, teachers, police, the clergy, healthcare workers, because these are the first points of contact for many people. So we need to come up with some training manual, training curriculum for training of gatekeepers, and this we are working on it at the moment. For media, we already have started working on that. For the other cadres or the other professionals, we're working on it. Then reduction on harmful use of alcohol as well as an intervention, and structural interventions in bridges, buildings, and railroads. This will require us to work with other government agencies, including the Ministry of Transport and the others. So this is something that for us, we feel is key to limit means or restrict means of suicide. And I'm just noting here that a lot of this falls outside of health. We have to do a lot of multi-sectoral collaboration and coordination to be able to succeed on this front. Then what are the collaboration and coordination mechanisms we have in place? So we were able to establish our national suicide prevention program at national level. County level hasn't happened at the moment, but we're working on sensitizing the counties on this to be able to come up with their own suicide prevention programs. Secondly, we have appointed a focal person for suicide prevention at national level. County level, we are going to do sensitization on this as well, because at county level, we already have the county mental health focal persons, and we felt instead of creating another cadre or another, another form of office in the county, why can't the county mental health focal person also serve as the county suicide prevention focal person? Thirdly, we have established a national multi-sectoral suicide prevention committee. You can see on our right, this is a very new committee. We just had our inaugural meeting last month on the 12th of July, and it's a multi-sectoral committee where we have representation from NGOs, CSOs, government agencies, the government chemists, pathologists who are very important, the civil registration, the Ministry of Interior, the police, and also we have representation from healthcare worker associations and also regulatory bodies. The County Multi-Sectoral Prevention Committee, Suicide Prevention Committee, is yet to be established. As I said, this is very recent for us at national level. We are yet to disseminate to the counties and sensitize the counties on the same. And 4 is we need to do a lot of education. Public education is key in suicide prevention because there's a lot of myths and misconceptions about suicide, which are hindering a lot of people from coming clean and being honest and asking for help. And this is really because of a lot of our cultural maybe and religious beliefs that we possess, and we're not able to ask for help, and we're not able to come out and seek services, mental health services, because there's already stigma attached to mental health. Now the stigma attached to suicide is even worse, because a lot of the time people are misunderstood, and it's assumed that you have everything going for you. Why are you being suicidal? Why are you having suicidal thoughts? And it's not treated like it can be bigger than that, that there's something else going on. Then commemoration of the World Suicide Prevention Day. We've been doing this in the country for the last few years. We had one last year on 10th of September. That's why we are doing this series of webinars to raise awareness about suicide prevention. So we'll be having webinars every week for the next coming weeks on suicide prevention. So that is on 10th of September. So this is what I'm showing here is just photos of the work that we've done around suicide prevention or commemoration of the World Suicide Prevention Day. This happened last year. So what happened last year is that, sorry, a minute. Sorry about that. So this is last year. Last year, we held 2 events, actually. As I said earlier, the population who is most affected by suicide are young people. Young people between the ages of 15 to 29. So what we did with 2 events last year, we did this where you can see where this is there was dance and music. This was actually co-created with young people. Youth organizations came on board and they came up with how they want to create awareness about suicide. And as for us, we would never have imagined this. We would probably come and give speeches, which would not have been effective. So what they did is that they had like spray cans. They had a wall, people were writing about how they feel, giving each other hope. And then they had a lot of music, a lot of dance, a lot of poetry, just to talk about suicide, talk about mental illness, talk about depression. And for us, it was very moving because the young people were able to speak to fellow young people and pass the message on suicide prevention. Next, we also had a cycling event. The following week, we had a cycling event. Creating hope through action is the theme for last year, and it's also the theme for this year, for the World Suicide Prevention Day on 10th of September. So we did a cycling event. We started at Mathare Hospital, and this is among the participants or the people who came for the cycling event. And it generated a lot of, it was also a way to create, make people be physically active, physically fit, but still talk about suicide in an environment where it doesn't, to reduce also the stigma around suicide. So I'll move now to the financial environment. There's gross underfunding of mental health. I think this is just not in Kenya, but across the globe. Nationally, we are spending less than 1% of our total health budget, according to the Task Force on Mental Health, And at county level, often many counties do not have a dedicated budget for mental health. What does the underfunding do? It leads to inaccessibility of mental health care. Mental health is more at tertiary level. It's more in the psychiatric units, in the mental health units, and we have less mental health services or non-existent mental health services at primary health care and at community level, where they are most needed, where they have the highest coverage of people. There's also limited promotion and prevention strategies for mental health, because if the funding is there, the funding will go more into curative approach to tackle severe mental illnesses and not really on promotion efforts, including workplace wellness programs, school mental health programs, and mental health and psychosocial support, even at community level. Then there's limited knowledge on mental health and suicide. This increases the stigma. People are scared of what they do not know. And they don't know much about suicide. They don't know much about mental health. So this is greatly impacting on stigma and propagating the stigma. We saw this during COVID as well. There's a lot of fear around COVID and what is COVID and how will I get COVID. And it was very similar even to the stigma which was around HIV a few years back. But they had to do a lot of awareness for us to be able to be at a level where we can have discussions about HIV. In this case, this is where we want to reach as mental health. We're able to openly talk about mental health and suicide, even at family settings, even on the dinner table, because we are scared. We think if we start asking our kids if they're having suicidal thoughts, because you're seeing their behavior, you're saying they might even say it, and you say, no, don't even think about it. Don't, we say, don't say it. I have the Swahili word for it. I don't want to use it, but it's, we are scared that if we encourage suicide or we talk about suicide, it's like we're encouraging suicide, but that's not the case. And I think also there's limited knowledge in terms of even our society. Last week, or is it a few days ago, we had so I will try and put my video off connection problems. So let me continue. I was here on improved financing for mental health. I think this is very important for us to have successful, effective, and impactful suicide prevention programs or strategies in place. Government spending has also increased, especially after COVID, because I think there was a lot of awareness about mental health, because mental health for a long time was misunderstood. And a lot of people associate mental health with very severe disease. and not on mental health or mental wellness of people even like me and you who are working, who are, you know, still contributing to the economy, but they have mental health challenges or mental health problems that they live with. And then I think that's all. That's all from my end. I want to give time for questions. So these are the references, these are the documents. And I got this quote, which I felt was very important or very touching. This life, this night, your sorry, your pain, your hope, it matters, all of it matters. I work a lot with young people, and I think for this generation of young people, they're able to express themselves. Probably they can express themselves in different ways than we would, but they're able to express themselves using poetry and art. And I think we need to cultivate that for them to speak about what's going on with them, because they do bear the highest burden. Suicide, also men. I think we need strategies on how to get men to talk. So for us, I think that's very important on how we can get men to open up and talk and seek help, because a lot of the times these suicides happen at our workplaces, in our homes, and you're there thinking, I did not see any signs. This person was so happy. Even with the famous people who died by suicide, you can, when they share the photos of the day before, even hours before, they were happy. They looked happy, because they had to give that persona so that people do not think that there's something wrong with them. So they had to show people that they're happy, they're okay, there's nothing going on with them. But suicide is very complex, it's very complicated. We need to talk. We need to talk. I think even as a country, we need to talk. A lot of us have to talk to our children. We have to talk to our family members. We have to talk to our colleagues, so that to know what is going on with people, because people are carrying a huge load. People are, there's a lot of people are going, they're doing well, they're successful. And you would assume that this side or self-harm. So I think this notion that we have that suicide fits a certain group of people, and all of us can have such thoughts, and it's normal to have such thoughts, but we need to seek help and talk about it. So I think for me, that is it. I will hand over to the moderator. Thank you very much, and I'll address the questions, I think, later after Imelda's presentation. Over to you, Matilda. Thank you.
Good afternoon. Thank you, Dr. Omar. That was a wonderful presentation. I personally really enjoyed it. I hope the participants also enjoyed it. So at this juncture, I want to welcome our next presenter, Madam Imelda. Are you already in the call? Maybe as we wait for Madam Imelda to join in, Dr.
Hello?
Omar. Yes.
I'm here.
Oh, beautiful. Thank you, Madam Imelda. Please feel welcome to today's webinar. We are so glad to have you in today's presentation. Just a minute. Yeah, thank you so much, Madam Imelda, for joining us. And we are very happy that you're going to give us something that you've all been waiting for a very, very long time. So Madam Imelda is going to cover a topic on criminalization of suicide. That's a very nice topic. So I want to tell you who this lovely lady is. Her name is actually Laureen Imelda Achieng. She is the CEO of Kenya Parliamentary Caucus on SDG and Business. She is a Kenyan lawyer, passionate about human rights and sustainable development. She is a beneficiary of Release Fellowship on Africa, Rights, Drugs, and the Law from London School of Open Society Foundation. She is also a recipient of the SDGs Fellowship, Copenhagen, courtesy of the Danish Foreign Affairs Ministry. She serves on the Board of Justice and Environmental Foundation as the chairperson of the consultants in policy and legislation processes. She spearheaded a parliamentary campaign on mental health known as Fungua Roho, which saw the mental health amendment
So good afternoon, colleagues. My name is Laureen Imelda Achieng. I work in Parliament under the Parliamentary Caucus on the Sustainable Development Goals and Business that was founded in 2017 by a group of members of Parliament from both houses of the National Assembly and Senate to champion issues to do with the United Nations Sustainable Development Goals. And one of the areas that we've been working on has been mental health. And as a result of that, we saw the enactment of an Mental Health Amendment Act of 2022. We are further working to promote other issues around mental health, and some of the other areas we are working on are on the issues of harm reduction, issues of narcotic and psychotropic Act amendment, and issues of suicide decriminalization. So for today, I'm happy to be here to share with you a few on our journey and a few things that we've seen in terms of legislative reforms, and also give you an update of where we are and what can we do together to achieve suicide decriminalization within the law. So I'll start with a brief introduction that in Kenya, out of 100,000 population, 5.6 is the rate of suicide prevalence currently. And then we have the UHC services, which were introduced ideally to help reduce suicide cases. Under the United Nations Sustainable Development Goals, mental health is measured according to the cases of suicide prevalence. And so within the UHC, then it is a requirement that also mental health is covered fully and that well-being is prioritized. Now, the World Health Organization estimates that globally we have 800,000 people who die by suicide. And according to them, then suicide is the leading cause of death amongst young people who are aged between 15 to 29 years of age. Now, we just been doing the mental health campaign on Fungua Roho. And through that campaign, we had this notion of using political voices because they relate more with the people, for them to popularize the mental health agenda in an attempt to reduce stigma and just to make people know that mental health is just a health issue, just like any other, and that everyone has a mental health state that needs to be protected, and we shouldn't stigmatize people around the issues of mental health, but instead we should openly talk about it, seek help, and be a friend and support each other to cope with our daily mental health issues. Now, I'll start by this story that you see. Recently we had we saw a clip of a man in Mombasa torching himself. The youthful man is the one we're seeing here. He was a graduate. It's called Robert Gituhu. He was an engineer graduate actually from 2021. And since then he had not gotten a job, and he slowly fell into mental illness twice before he had disappeared from home, and they had found him. And at this time, really, he was just, out of his normal mental state, loitering, and he got into a bit of discussion and then prompted him to make it like a joke that he's going to touch himself. And, out of that, there was also someone who was encouraging him. and even gave him a lighter to touch himself. So this has been a very recent, mental health case in public, which has attracted different views, and has, human rights activists stating that, well, the guy who also gave him the lighter should also be charged with assisting suicide. We all know the guy survived, but later on passed on. Very unfortunate. So this is just, an example of how young people are really easily getting into depression because of the societal issues. Now, in the context of our law, penal code is what has had suicide as a crime. Under the penal code, Cap 66 of the laws of Kenya, under section 226, we have attempted suicide as a criminal offense under the penal code. Further, it states that any person who attempts to kill himself is guilty of a misdemeanor. Under the same penal code, under section 209, we have an offense of entering into a suicide pact. And entering into a suicide pact is a situation where two or more people, agree that you're gonna kill me, or between me and you, you're my witness. This other person gets to kill me, and I've actually given the mandate and I've allowed it. So that is a suicide pact. So that section has actually criminalized that, and it has further stated that in the event that there's someone who is found guilty of entering a suicide pact, it shall be considered as a manslaughter, which is also put as a defense in court. Further, the section has also spoken about aiding suicide under section 225, which is basically very, mysterious in a way. It's not really clear on aiding suicide. And as a cause of that, then, mental issues are basically criminalized. Suicide is basically criminalized to its entirety. Now, given examples of other jurisdictions, and Kenya has two sources of our law. Some of our law are original laws that we adopted from the colonial master, the English laws, and some of our laws also come from India laws. So let's look at India, where we borrow some of our laws, and we can then further look at the UK, and then we can also look at some of the leading jurisdictions who have upheld mental health and upheld suicide decriminalization. Now, in India's penal code, suicide is actually, there's punishment for attempted suicide. So it's actually a criminal up to now. In 2017, development, they had a Mental Health Care Act of 2017 that limited the scope for the code to be implemented. And now it introduced a clause that stated that any person who attempts to commit suicide shall be presumed, unless proved otherwise, to have severe stress and shall not be tried and punished under the said code. Now, India still, the state governments are required to provide adequate care and rehabilitation for such individuals to prevent a recurrence of an attempted suicide. Implications of decriminalization, of course, are reduced stigma and free talk for India. So they've been able to gain some progress by introducing the act and then decriminalizing suicide within the act. So now, I think that is that. We can see where we borrow our law already. They've decriminalized. Under the UK laws, the laws existed in 1961, the laws against attempted suicide. Now, suicide is perceived as an immoral, criminal offense against God and also against the crown. And possessions of a person who, as they say, committed then, because it was a crime, committed suicide, could forfeit the property to the crown. In the US, there's no state that has criminalized suicide or attempted suicide, except for the common law crimes, laws of right and of claim. Now, the right to die or voluntary euthanasia or physician-assisted suicide or mass killings or terminal illness or incurable pain still exist, and that's why we have a lot of people just deciding on behalf of their family, or that this person is going through so much. Let's just admit euthanasia to assist them die respectful and a dignified death, which is painless. Now, on to Kenya again. For us, we really now should ask ourselves the question, the section 209 of the Penal Code on the Pact. Is it really necessary to have it as a defense? Because it brings then mischief, and it's subject to being abused. Do we really need it? Then section 225, of course, on aiding the physical. Now, there are two aspects. Someone can actually aid you in the essence of a physician, which is dignified and within good intentions. But then also there is that aiding where we have like online bullying, where people can actually bully someone and push them to the extent of dying by suicide. We also have situations where, as you can see the example in Mombasa, the guy was given a matchbox, and some people were really cheering him on to touch himself. So you see that is also aiding. So how do we then define aiding? There is need to look at aiding from a criminal view and from a health view. Then on the section 226 on the attempting suicide, why is it crucial then to have it in that law? The ideal thing is actually because we can see the person who has attempted suicide has gotten to a point of being proven to be mentally ill. Then we need to scrap it off and put it as a health need. Now, what then would be the proposed amendments? Now, deleting section 209, which has set up the Suicide Pact as a defense, and having an alternative criminally viable charge. Then delete with section 225 that on the aiding, criminalizing the act of encouraging a person to commit, in addition to aiding the commission of suicide. We need to look at the difference between, what are the emerging aspects, bullying, cyberbullying, or physical or online, and we also separate it from that of treatment and medical, and then we can then come up with a clear-based difference between what aiding a person is, because it's not really defined, and there are different instances which can then be interpreted differently in a court of law. Then we also need to delete entirely section 226, which speaks on attempting suicide as a criminal offense, and then have it replaced elsewhere in the health laws as a mental health illness, and something that then would need you to have a different sort of treatment, and not a treatment within the law, but under the health system. So now, where can we then anchor these amendments and legislative proposals? One would be then to have the Mental Health Act, which was then amended just the other day in 2022, further amended to provide mechanisms and programs for preventing suicide and supportive measures to prevent and reduce the occurrence and reoccurrence of suicide and attempted suicide. We also need to have a different law, a bill on suicide decriminalization, a bill for 2023. And actually that bill, there's a bill underway in Parliament that has not yet been tabled. It's still going through the legislative processes. And so as soon as it is out, we will share with you and other stakeholders. we are all pushing for that bill to be tabled and be passed. A bill on its own, just entirely decriminalizing suicide and making it as a health bill that then seeks to address issues under suicide, issues on treatment and prevention. Now, what then is the flip side? There are issues of protests, like someone protests. The other day we had the case of Mackenzie. And it's a big problem going on right now in Kilifi. How do you treat those people who have someone like Mackenzie himself? He's a perpetrator. He's pushed people to the extent of people starving to death. But himself, it's hard to really determine whether is he normal, is he in his right state of mind, is he doing it intentionally, or is he protesting anything? Because it's really hard to determine, and that it falls under religion at the same time. So, and religion, has talked about the issues of fasting and all that. So that is a challenge, which I know religion and protest and self-immolation. How do you then isolate the same and then determine that in as much as this person was trying to do a religious act or a protest, it led to this? Should we charge them or should we treat them as someone with mental illness? Then also in the case of suicide bombing, people can really try and abuse that. A failed suicide bomber, you say, yeah, it's attempted suicide, and you've totally scrapped off the attempted suicide as a crime. So this was someone who was also a terrorist. So, it's very good to actually define that in some instances, even in as much as you are a failed attempted suicide victim, you would still be able to be charged as a criminal, which can then be defined in the bill. It should then define instances which are extremely criminal, and then instances where it's actually a mental health issue that needs to be looked at. If not, then it can be easily abused as a defense. And then also, even if you decriminalize, as we are saying, it's not the final. There's still need for comprehensive health programs to reduce its incidences, psychosocial support, and other drivers. Look at the root cause research, and then try to address it extremely within our budgets. Also, as a government, prioritize it, budget for it, and implement the programs that need to be done. So then, for this law that is there, basically it was, as I said, it's still undergoing the legislative processes to be analyzed, reviewed before it is tabled. But we have identified it has a promoter, but we've identified other members who would possibly bring such a law. Should that not be tabled, we have tried to identify. At the National Assembly, we've identified the former chairperson for health, Honorable Sabina Chege, and then we've also identified in Senate Senator Habida Kibwana, whom we would then try to introduce that. Being that it's not a money bill, it can be introduced from any of the houses, from Senate or from the National Assembly. Then it will go through of course, the legislative processes before it is tabled. Once it's tabled, of course, pre-publication scrutiny should be done. The first reading and then public participation. We get the views of the public. It's brought again for the second reading, where then the members of parliament are able to discuss and give their views. Then it is then brought again for a third reading, which is the committee of the whole house. This is where they get to vote for the bill. And once it's passed by this, then it is taken to signing and it's passed as a law. Now, there is one famous guy who spoke and said, it's called Kelvin Wanyambura. He said, you can never run away from pain. You only go through it. So for mental health, it is a state, it is something which people try to avoid. People think like, we can go, I can numb my feelings. I can just take a lot of alcohol and drugs. You can't run away from that. You're only postponing your problem. So the only way we can deal with mental health is going through it, walking through the challenges and addressing the issues. And I hope in this journey that we've talked about, then we get to walk together and support each other to ensure that we decriminalize suicide in Kenya. Thank you very much.
Wow, very impressive presentation. Well done, Dr. Madam Laureen Achien. A very nice presentation indeed. So at this juncture, I'd like to go through maybe the charts and see the questions that could be in place. I already have some in place, and when we went off air, I don't know the IT guy where we lost some of the questions, but I'll try to find out one of the questions. I think that one will go to Dr. Omar. Dr. Omar, I think this one goes to you. Jennifer Otieno, she was just asking for clarification. Can someone indulge in actions that are like committing suicide, e.g., just being reckless with sexual life, not bothering about HIV infection, among others?
Yeah, Matilda. So,
number one.
Yeah.
Maybe you can answer that first.
Okay. So in terms of what you've described, that's risky behavior or indulging in risky behavior. And the correlation here with suicide, as I said, suicide is very complex. Some people die by suicide, but they do not have an underlying mental illness. It happens. So for this one is mainly the risky behavior. Probably they're going through mental health challenges or mental health problems that they don't want to address. So engaging in risky behaviors, or they're also probably having an underlying mental health disorder. So they need to be assessed and they need to be supported to be able to determine why they would partake in that risky behavior. And maybe the other thing is also there are people who cut themselves because there's self-harm and there's suicide, and they're very different. There are people who can cut themselves just to feel alive. They don't want to die by suicide. They don't want to die. Their intention is not to die. Some say that maybe I don't feel anything. So when I cut myself and then I get, the physiological reaction where my heart rate goes up, I start feeling sweat. That is when I know I'm alive. So and they seek help or they bandage themselves and they're okay. That's self-harm. That's different from suicide. It's totally different. For suicide, for people who attempt suicide, the intention is to die. So I think there's a lot of confusion about the two. So we need to do a lot of awareness on that. Should I, Matilda, there are so many questions I can see here. Should I just answer the ones?
Yeah, the ones you think are relevant to your side, go ahead.
Okay. So I will answer the one on why do people commit suicide, risk factors and warning signs. I think we said we don't say commit suicide anymore, right? I think that's a term we should stop using because we are also criminalizing it. I think we should say, why are people dying by suicide? So there are a number of reasons, there are a number of risk factors that people have. As I said, we are having a series of webinars which will be covered by my colleagues in the upcoming webinar, but maybe just briefly, if we look at the risks for suicide, there are several risks that individuals are exposed to. Sometimes even history of suicide, maybe a close member of the family, a close friend died by suicide. That is a big risk factor for some people. Those are individual factors. So there's health system risk factors, there's community and relationship risk factors, and individual factors. So in terms of the health system, there's barriers to accessing health. I just want to project this because I can't go through all of it. It is in our strategy. So let me just share my screen so that you're able to just see. It is in the strategy. And I think we will share this here. I don't know if you can see my screen. Let me enlarge a bit. This is in our national strategy. If you Google it, the National Suicide Prevention Strategy, Kenya, you will see it. It's available online. This is important. These are the risk factors. They have been divided according to more of health system problems community problems or community risk factors and individual risk factors. So at health system level, just even having barriers to access to health is a risk factor. Having access to means there's a gun in the house, that is a risk factor. Maybe I was thinking of suicide or I had suicidal thoughts, but I didn't know how to do it. But now there's a gun, there's poison, there's pesticide. I live in a farm, there's pesticides available. Inappropriate media reporting and social media, that's a huge risk factor, especially in the fact that even on social media and in the media, you find that even the suicide note is put there and the means of suicide, and it's even very detailed explanation of how the person died by suicide. This will encourage others also to, attempt the suicide, because some may have the thoughts, but they don't have a plan yet. Then stigma, the stigma associated with help seeking. If you keep saying, I'm going to see a therapist, I'm going to look for mental health support, people will keep asking you, what's wrong with you? There's a lot of stigma attached to it, so you'd rather lie. That's why when we are taking sick offs, we don't say we are taking sick offs to go to the mental health facility or to go see a psychologist. We are taking sick off because I have issues of hypertension, diabetes, backache, headaches, migraines, but I will not say that I'm going for mental health support. Community level now, there's disasters, wars, conflict, COVID-19 was a risk factor for many people. Stresses of dislocation, and also discrimination, abuse as well, even if it's childhood, traumas you are carrying every single day from your childhood or something that happened to you. There's also the lack of social support and isolation. I think in the society now, where the direction we are going, we're building, we're building higher walls. We are being more isolated than the previous generations. And a lot of the time, the friends that you have are all on social media. You don't know any real people. You don't have any physical connections with people or physical interaction with people. Conflict in relationships, loss, grief is a risk factor. If you see individual factors, you can see them here. Previous suicidal attempts. Someone who has attempted suicide previously is at a high risk of dying by suicide. People with mental disorders, I think what you can see is risk factors. People used to think it's because of mental problems, it's because of mental health issues that this person is dying by suicide. But you can see a lot of the risk factors are not mental health, are not due to a diagnosis of mental health disorder. Harmful use of substance and alcohol, loss of jobs, financial losses. We saw that during COVID as well. A lot of people were retrenched. Hopelessness, chronic pain, people who have terminal illnesses, family history of suicide. That's also a big risk factor for certain individuals. Genetic. There are also some people who it's not explained. It's probably genetic or biological factors which are not well understood. So let me stop sharing this. I just wanted to highlight that. So let me go to the other question on warning signs. That one, I think it will be covered. There's a team there's a group, a webinar which we will address on awareness. So we can cover a bit of this. I don't want to go into that. And then can we be facilitated by the ministry to organize suicide awareness events at the county level? This actually, we are planning this year for World Suicide Prevention Day. We are going to one of the counties. Matilda is actually working on that. Then why is attempted suicide a criminal offense and not considered mental illness? I'll leave that one to Imelda, sorry, to answer that. Does Kenya have a system that helps in data collection from the health center to the National Hospital concerning suicide deaths? Yes, we do have the health information system. We have the DHIS2 in Kenya. It reports on suicide deaths. Yes, we do capture it at facility level, and then they are reported again in the civil registration service. But the problem, what I had said, is the quality of that data. Data is not being captured, and also some of the individuals are even not informing the facility or the person who's supposed to certify the death that this was a suicide. So they would say that Amelala to Yani, they slept, they died. They won't say that they took an overdose. They will not say that there were other means that they took, how they found them. Because if the person dies by suicide, it's supposed to be a police investigation. And maybe people do not want that. Also, they're scared of how it will affect their status in the community. So a lot of people would lie about that. So the other question is for Imelda. I can see for Imelda, there's a question here as well for her. Okay. A lot of the questions are coming in, I think now are on for Imelda. Yeah. Over to you, Imelda.
Over to you, Imelda.
Okay, thank you. I'll answer a question on, is the Fungua Roho initiative available in all the counties in Kenya, since it can help curb this menace? For now, the project ended because it was a project that was in response to the COVID-19 increased cases of mental health. And it was also targeting the enactment of the Mental Health Amendment Act 2022. So that project ended, but we will initiate other projects soon on mental health, and we can reach out to counties. So we work with the Council of Governors. We work also with the County Assemblies Forum. We work with the Society of Clerks at the table. So through them, then you can reach out and they can alert you whether there are programs from Parliament on the mental health, especially within the Parliamentary Caucus on the SDGs. Then the other question was, why is it difficult to delete Section 209? Does it mean it has been of importance in controlling suicide and parasuicide in the country? Do we have data on people who have been convicted of parasuicide? On the data, I'm not sure. I'd leave that to Ken H and the ministry. But on the reason why it's difficult to delete that, because then when you're saying that people entered into a pact, one, it's that on that issue, it should ideally be seen as you murdering another individual. Despite having been given the authority, it looks as murder. And so there is that defense where it's then put as a manslaughter. So the question is, why should it be a manslaughter, whereas this other person had their rightful mind while they were doing it? Because they were not the person who was then entering the pact. They were not entering it as a result of mental health illness. They were entering it as they had their mental health mind, unless all the people involved then had mental health illness. There are some people in that state who had been in their clear mind. So if you delete it, then, there is that mischief of someone coming in and saying that this was a case of suicide. They told me just, this and this, we had agreed, and then it failed. We had agreed to all of us, we're going to die, or I'm going to kill this person and then kill myself. And such has been happening. You see the situations where someone has killed the wife and then killed themselves. I mean, what prevents such a person from saying that we were suffering and so me and my wife had agreed that we want to die, so we agreed that I shoot her and then I shoot myself first, or she dies and then I kill her and then I kill myself first. It can really be abused if it's not really defined. So before it is deleted, then we need to find the clear definition of an amendment that then will replace it to address the mischief that would be lying within that, to ensure that that section is actually serving its rightfully intended purpose and it cannot be abused. Now, I think on the issue of gun holder, Dr. Omar has addressed that. I'm wondering, which other questions? Mine can't see more. Let's see how they're coming. Which other questions were directed to me? Dr. Omar?
Yeah, there was a question about, I think this one which I can also answer is, do you have any confirmed case of a person jailed because of attempting suicide in Kenyan records? In Kenyan records, I don't think we do have that.
Okay, so sorry, I was talking on when I was muted. This is for Imelda. There's a question from Martin Nafuko, and the question reads, what can you say about traditional deterrent measures to suicide, e.g., ostracization and mistreatment of persons who commit suicide? Does the modern court confer jail and fines as a lesson to others who may attempt such thing or such a thing?
Well, the modern law currently, once it's criminalized attempted suicide. When you go to court, it's up to your defense team to prove that you are mentally challenged, or then it was a case of terrorism, an act of terrorism, or what drove you. So the driving will determine whether you're actually seen as a criminal, or you're seen as someone who then is not in their rightful mind. Remember, before you even go any proceedings in court, then they have to determine your state of mind. So that would, if it's a mental health issue, it would have been determined way earlier before you even presented in court. But the challenge would be you hang in between the criminal justice system. This is, you're then there maybe in Mathare as someone who has been arrested, and then you've been determined that you have a mental illness. So you're still in the records of the court, and you're still supposed to be given treatment. And so your case is just hanging in there. There's no proper transfer channels where now this one is a patient. Let us release them. Let us delete their records. Let them seek treatment, and after treatment, some other care to avoid relapse. There's no that clear transition. You just hang in there. Once you're declared mentally, then you're left. You'll be hanging there in Mathare. That is the situation right now. On the issue of traditional, please repeat the traditional methods of dealing with mental illness.
Maybe I can assist with that.
Yes, I thought so.
I think recent evidence is showing that, countries are scared of criminalizing suicide because they are worried that it will also, it was a deterrent for people to attempt suicide or even try to, die by suicide. But evidence is showing it really isn't. It might, once, for countries like Ghana has recently decriminalized suicide, for countries which have decriminalized suicide, the number may start going, it may look like it's going up, that we're having more people, but it's because also we are probably improving our reporting structures for suicide. So, and then it will just plateau at a certain level. Because as I said, a lot of the times there's worry that maybe we need to punish these people for them not to try this again, but that does not work. Because remember, this is a person who has reached the end and who has lost all hope. So whatever measures you're using to discipline them or make sure that they don't do this again, or fine them or jail them, will not work, because we've seen of cases whereby even if they are arrested with an attempted suicide, complete the suicide within the police cells or within the prison system. So still we are losing that person. And I think the criminalization of suicide will also need a lot of sensitization to be done, even to the public, to be able to understand what suicide is all about. So thank you. I think, is there another question? Matilda, over to you.
Thank you so much, Dr. Omar and Madam Imelda. I think those are very nice, it was very nice presentations, and also I like the answers that you've given to the participants. I hope the participants felt answered. But as you've said, this is just the beginning. They can continue joining, and more information is coming regarding the same. And some things, if you feel are not clearly answered, they'll actually get answers as you go along. Thank you so much. I think over to you, the IT person.
Thank you as well, Dr. Omar, Imelda, and Dr. Matilda for joining us today for this interactive session. As mentioned, this is a webinar series that will be continuous, so kindly look out for notifications on your emails for the next upcoming sessions that we'll be holding. For the meantime, we are working on the CPD points, and as relayed in our previous communications, can you just be patient with us while we try and streamline this process, and you'll receive all of the CPD points for the sessions you have participated in. Thank you once again for joining us, and do have a wonderful afternoon. Good day.
Good day. Thank you so much for having us.
Thank you too.
Bye-bye.
Have a lovely evening.